Chapter 2. Episodic impairment of consciousness. Temporary loss of consciousness may be caused by transient impaired cerebral perfusion, the presumed mechanism for syncope, cerebral ischemia, migraine, epileptic seizures, metabolic disturbances, sudden increases in intracranial pressure, ICP, or sleep disorders. These conditions may be difficult to distinguish from anxiety attacks, psychogenic non-epileptic spells, PNESs, panic disorder, and malingering, which should always be considered. Syncope is defined as an abrupt, transient, complete loss of consciousness, associated with inability to maintain postural tone, with rapid and spontaneous recovery. Shen et al. 2017. Syncope may result from both cardiac and non-cardiac causes. Specific causes of a transient impairment in cerebral perfusion include vasovagal episodes, typically a surge in parasympathetic autonomic tone, decreased cardiac output secondary to cardiac arrhythmias, outflow obstruction, hypovolemia, orthostatic hypotension, and decreased venous return. Cerebrovascular disturbances from transient ischemic attacks of the posterior cerebral circulation perfusing the brainstem, or cerebral vasospasm from migraine, subarachnoid hemorrhage, or hypertensive encephalopathy may result in temporary loss of consciousness. Situational syncope may occur in association with cough, micturition, defecation, swallowing, Valsalva maneuver, or diving. These spells are often mediated via a decrease in venous return to the thorax and/or an increase in sympathetic tone. Metabolic disturbances due to hypoxia, drugs, anemia, and hypoglycemia may result in frank syncope or, more frequently, the sensation of an impending faint, presyncope. Absence seizures, generalized tonic-clonic seizures, and complex partial seizures are associated with alterations of consciousness and are usually easily distinguished from syncope by careful questioning. Seizures may be difficult to distinguish from PNESs, panic attacks, and malingering. In children, breath-holding spells, a form of syncope, discussed later under miscellaneous causes of altered consciousness, can cause a transitory alteration of consciousness that may mimic epileptic seizures in this population. Although rapid increases in ICP, which may result from intermittent hydrocephalus, severe head trauma, brain tumors, intracerebral hemorrhage, certain severe metabolic derangements or Rey syndrome, may produce sudden loss of consciousness. Affected patients frequently have other neurological manifestations that lead to this diagnosis. In patients with episodic impairment of consciousness, diagnosis relies heavily on the clinical history described by the patient, and obtaining a detailed history from unaffected observers is often essential to clarifying the diagnosis. Laboratory investigations may also provide useful information. In a minority of patients, a cause for the loss of consciousness may not be established, and these patients may require longer periods of observation. Table 2.1 compares the clinical features of syncope and seizures. Syncope. The pathophysiological basis of syncope is the temporary failure of cerebral perfusion, with a reduction in cerebral oxygen availability. Syncope refers to a symptom complex characterized by lightheadedness, generalized muscle weakness, giddiness, visual blurring, tinnitus, and gastrointestinal, GI, symptoms. The patient may appear pale and feel cold and sweaty. The onset of loss of consciousness generally is gradual but may be rapid if related to certain conditions such as a cardiac arrhythmia or in the elderly. The gradual onset may allow patients to protect themselves from falling and injury. Factors precipitating a vasovagal syncopal episode, also known sometimes as a simple faint, include emotional stress, unpleasant visual stimuli, prolonged standing, venipuncture, and pain. Although the duration of unconsciousness is brief, it may range from seconds to minutes. During the faint, the patient may be motionless or display myoclonic jerks but never tonic-clonic movements. Urinary incontinence is uncommon. The pulse is weak and often slow because patients may be briefly bradycardic, from parasympathetic tone, and vasodilated. Breathing may be shallow and the blood pressure barely obtainable. As the fainting episode corrects itself by the patient becoming horizontal, normal color returns, breathing becomes more regular, and the pulse and blood pressure return to normal. After the faint, the patient experiences some residual weakness, but unlike the postictal state, confusion, headaches, and drowsiness are uncommon. Nausea may be noted before the episode and may still be present when the patient regains consciousness. The causes of syncope, which may often overlap, are classified by their pathophysiological mechanism, box 2.1, but cerebral hypoperfusion is always the common final pathway. Rarely, vasovagal syncope may have a genetic component suggestive of autosomal dominant inheritance, Klein et al. 2013. Wheeling et al. 2009, reviewed the clinical features of the successive phases of syncope, as discussed earlier. History and physical examination. The history and physical examination are the most important components of the initial evaluation of syncope. Significant age and sex differences exist in the frequency of the various types of syncope. Syncope occurring in children and young adults is most frequently due to hyperventilation or vasovagal, vasodepressor, attacks and less frequently due to congenital heart disease, Lewis and Dalla, 1999. Fainting associated with benign tachycardias without underlying organic heart disease also may occur in children. Syncope due to basilar migraine is more common in young females. Although vasovagal syncope can occur in older patients, Tan and Perry, 2008, when repeated syncope begins in later life, organic disease of the cerebral circulation or cardiovascular system usually is responsible and requires exhaustive investigation. A thorough history is the most important step in establishing the cause of syncope. The patient's description usually establishes the diagnosis. The neurologist should always obtain as full a description as possible of the first faint. The clinical features should be established, with emphasis on precipitating factors, posture, type of onset of the faint, including whether it was abrupt or gradual, position of head and neck, the presence and duration of preceding and associated symptoms, duration of loss of consciousness, rate of recovery, and sequelae. If possible, question an observer about clonic movements, color changes, diaphoresis, pulse, respiration, urinary incontinence, and the nature of recovery. Be certain to ask about any prior events, and gather these same details for each event that the patient recalls. Cardiac syncope is defined as syncope caused by bradycardia, tachycardia, or hypotension due to low cardiac index, blood flow obstruction, vasodilation, or acute vascular dissection, Shen et al. 2017. Cardiac syncope should be suspected in patients with known cardiac disease. Clues in the history that suggest cardiac syncope include a history of palpitations or a fluttering sensation in the chest before loss of consciousness. These symptoms are common in arrhythmias but do not definitively establish that diagnosis as the cause for the syncope. In vasodepressor syncope and orthostatic hypotension, preceding symptoms of lightheadedness are common. Episodes of cardiac syncope generally are briefer than vasodepressor syncope, and the onset usually is rapid. Episodes due to cardiac arrhythmias occur independently of position, whereas in vasodepressor syncope and syncope due to orthostatic hypotension the patient usually is standing. Attacks of syncope precipitated by exertion suggest a cardiac etiology. Exercise may induce arrhythmic syncope or syncope due to decreased cardiac output secondary to blood flow obstruction, such as may occur with hypertrophic cardiomyopathy with dynamic outflow obstruction, or with aortic or subaortic stenosis. Exercise syncope also may be due to cerebrovascular disease, aortic arch disease, congenital heart disease, severe stenosis of any of the cardiac valves, pulseless disease, Takayasu disease, a type of vasculitis, pulmonary hypertension, anemia, hypoxia, and hypoglycemia. A family history of sudden cardiac death, especially in females, suggests the long QT syndrome. Post-exercise syncope may be secondary to orthostasis in the setting of dilated vascular beds in the large muscles. Cardiac output may normalize faster than systemic vascular resistance. Vasovagal syncope brought on by relative hypovolemia, in a setting of dilated vasculature, or autonomic dysfunction. A careful and complete medical and medication history is mandatory to determine whether prescribed drugs have induced either orthostatic hypotension or cardiac arrhythmias. To avoid missing a significant cardiac disorder, one should always consider a comprehensive cardiac evaluation in patients with exercise-related syncope. Particularly in the elderly, cardiac syncope must be distinguished from more benign causes because of increased risk of sudden cardiac death. Anderson and O'Callaghan, 2012. The neurologist should inquire about the frequency of attacks of loss of consciousness and the presence of cerebrovascular or cardiovascular symptoms between episodes. Question the patient whether all episodes are similar, because some patients experience more than one type of attack. In the elderly, syncope may cause unexplained falls lacking prodromal symptoms. With an accurate description of the attacks and familiarity with clinical features of various types of syncope, the physician will correctly diagnose most patients. Brignol et al. 2006. Shen et al. 2004. But confirmatory testing to rule in, or to exclude, some high-risk diagnoses may be required. Features that distinguish syncope from seizures and other alterations of consciousness are discussed later in the chapter. After a complete history, the physical examination is of next importance. Examination during the episode is very informative but frequently impossible unless syncope is reproducible by a Valsalva maneuver or by recreating the circumstances of the attack, such as by position change. In the patient with suspected cardiac syncope, pay particular attention to the vital signs and determination of supine and erect blood pressure. Normally, with standing, the systolic blood pressure is stable or rises and the pulse rate may increase. An orthostatic drop in blood pressure greater than 15 mm Hg may suggest autonomic dysfunction. Assess blood pressure in both arms when suspecting cerebrovascular disease, subclavian stele, or Takayasu arteritis. During syncope due to a cardiac arrhythmia, a heart rate faster than 140 beats, min often indicates that the rhythm is not sinus tachycardia, may be a supraventricular tachycardia, an ectopic atrial or ventricular tachycardia, or atrial fibrillation or flutter, whereas a bradycardia with heart rate of less than 40 beats per minute suggests complete atrioventricular AV block or a prolonged sinus pause. An irregular pulse indicates possible atrial fibrillation but may also be seen with frequent premature atrial or ventricular contractions, and with intermittent AV block. Vagal maneuvers, which include Valsalva and cold water to the face, sometimes terminate a supraventricular tachycardia. Carotid sinus massage may also be effective, but this maneuver is not advisable in the acute setting because of the risk of cerebral embolism from potential atheroma in the carotid artery wall. In contrast, an ectopic atrial or ventricular tachycardia will usually not be terminated by vagal maneuvers. It is recommended that all patients with syncope undergo a resting electrocardiogram as part of their initial evaluation. Shen et al. 2017. All patients with syncope should also undergo cardiac auscultation for the presence of cardiac murmurs and abnormalities of the heart sounds. Possible murmurs of concern include aortic stenosis, hypertrophic cardiomyopathy with outflow tract obstruction, and mitral valve stenosis. An intermittent posture-related murmur may be associated with an atrial myxoma. A systolic click and late systolic murmur of mitral regurgitation in a young person suggests mitral valve prolapse. A pericardial rub suggests pericarditis. The finding of a murmur, rub, or abnormal click in a patient with syncope should prompt the physician to order an echocardiogram. All patients should undergo observation of the carotid and jugular venous pulses and auscultation of the neck. The degree of aortic stenosis may be reflected at times in a delayed or weakened carotid upstroke. Carotid, ophthalmic, and supraclavicular bruits suggest underlying cerebrovascular disease. Jugular venous distension suggests congestive heart failure or other abnormal filling of the right heart, whereas a very low jugular venous pressure suggests hypovolemia. Carotid sinus massage should be avoided in patients with carotid bruits but may be useful in patients suspected of having carotid sinus syncope. It is important to keep in mind that up to 25% of asymptomatic persons may have some degree of carotid sinus hypersensitivity. Carotid massage should be avoided in patients with suspected cerebrovascular disease, even if they have no carotid bruit, and when performed should be under properly controlled conditions with electrocardiographic, ECG, and blood pressure monitoring. The response to carotid massage may be vasodepressor, cardio-inhibitory, mixed, or minimal. Causes of syncope. Cardiac arrhythmias. Both bradyarrhythmias and tachyarrhythmias may result in syncope, and abnormalities of cardiac rhythm due to dysfunction from the sinoatrial (SA) node to the Purkinje network may be involved. Always consider arrhythmias in all cases in which an obvious alternative mechanism is not established. Syncope due to cardiac arrhythmias generally occurs more quickly than syncope from other causes. Cardiac syncope may occur in any position, is occasionally exercise-induced, and may occur in both congenital and acquired forms of heart disease. Although palpitations sometimes occur during arrhythmias, others are unaware of any cardiac symptoms. Syncopal episodes secondary to cardiac arrhythmias may be more prolonged than benign syncope and often occur with less warning. Patients may injure themselves significantly during their fall. The most common arrhythmias causing syncope are AV block, SAW block, and paroxysmal supraventricular and ventricular tachyarrhythmias. AV block describes disturbances of conduction occurring in the AV conducting system, which include the AV node to the bundle of His and the Purkinje network. SAW block describes a failure of consistent pacemaker function of the SAW node. Paroxysmal tachycardia refers to a rapid heart rate that comes on intermittently. It may be secondary to an ectopic focus or reentrant loop outside the SAW node but above the ventricle, supraventricular, or it may be from a source below the AV node, ventricular. In patients with implanted pacemakers, syncope can occur because of pacemaker malfunction. Atrioventricular block, AV block, is probably the most common cause of arrhythmic cardiac syncope. The term Stokes-Adams attack describes disturbances of consciousness occurring in association with a complete AV block. Complete AV block occurs primarily in elderly patients and is often also seen in patients with a history of aortic valve disease. The onset of a Stokes-Adams attack generally is sudden, although a number of visual, sensory, and perceptual premonitory symptoms may be experienced. During the syncopal attack, the pulse disappears and no heart sounds are audible. The patient is pale and, if standing, falls down, often with resultant injury. If the attack is sufficiently prolonged, respiration may become labored, and urinary incontinence and clonic muscle jerks may occur. Prolonged confusion and neurological signs of cerebral ischemia may be present. Regaining of consciousness generally is rapid. The clinical features of complete AV block include a slow pulse and elevation of the jugular venous pressure, sometimes with Cannon waves. The first heart sound is of variable intensity, and heart sounds related to atrial contractions may be audible. An ECG confirming the diagnosis demonstrates independence of atrial P waves and ventricular QRS complexes. During Stokes-Adams attacks, the ECG generally shows ventricular standstill or a very slow ventricular escape rhythm, but ventricular fibrillation or tachycardia also may occur. Sinoatrial block, SAW block, may result in dizziness, lightheadedness, and syncope. It is most frequent in the elderly. Palpitations are common, and the patient appears pale. Patients with SAW node dysfunction frequently have other conduction disturbances, and certain drugs, e.g., verapamil, digoxin, beta blockers, may further impair SAW node function. On examination, the patient's pulse may be regular between attacks. During an attack, the pulse may be slow or irregular, and any of a number of rhythm disturbances may be present. Paroxysmal tachycardia. Supraventricular tachycardias include atrial fibrillation with a rapid ventricular response, atrial flutter, AV nodal reentry, and the Wolff-Parkinson-White syndrome, AV reentry involving an accessory pathway. These arrhythmias may suddenly reduce cardiac output enough to cause syncope. Ventricular tachycardia may result in syncope if the heart rate is sufficiently fast, and ventricular fibrillation will almost always result in nearly immediate syncope. Ventricular arrhythmias are more likely in the elderly and in patients with cardiac disease. Ventricular fibrillation may be part of the long QT syndrome, which has a cardiac-only phenotype, or may be associated with congenital sensorineural deafness in children. In most patients with this syndrome, episodes begin in the first decade of life, but onset may be much later. Exercise may precipitate an episode of cardiac syncope. Long QT syndrome may be congenital or acquired and sometimes is misdiagnosed in adults as epilepsy. Acquired causes include cardiac ischemia, mitral valve prolapse, myocarditis, and electrolyte disturbances. There are also many drugs that can prolong the QT. In the short QT syndrome, signs and symptoms are highly variable, ranging from complete absence of clinical manifestations to recurrent syncope to sudden death. The age at onset often is young, and affected persons frequently are otherwise healthy. A family history of sudden death in a patient with a short QT may indicate a familial short QT syndrome inherited as an autosomal dominant mutation. The ECG demonstrates a short QT interval and a tall and peaked T wave, and electrophysiological studies may induce ventricular fibrillation. Brugada syndrome may produce syncope as a result of ventricular tachycardia or ventricular fibrillation. Brugada et al. 2000. The ECG in Brugada syndrome may or may not show a typical Brugada pattern at rest, i.e., an incomplete right bundle branch block in leads V1 and V2 and significant downsloping street elevation leading to inverted T waves in those two leads. Reflex cardiac arrhythmias. The hypersensitive carotid sinus may be a cause of syncope in the elderly, most frequently men. Syncope may result from a reflex sinus bradycardia, sinus arrest, or a V-block, peripheral vasodilatation with a fall in arterial pressure, or a combination of both. Although 10% of the population older than 60 years of age may have a hypersensitive carotid sinus, not all such patients experience syncope. Accordingly, consider this diagnosis only when the clinical history is compatible. Carotid sinus syncope may be initiated by wearing a tight collar, by rapidly turning the head, including when patients do so on their own, or by carotid sinus massage on clinical examination. When syncope occurs, the patient usually is upright, and the duration of the loss of consciousness generally is a few minutes. On regaining consciousness, the patient is mentally clear. Unfortunately, no accepted diagnostic criteria exist for carotid sinus syncope, and the condition is likely overdiagnosed. Syncope in certain patients can be induced by unilateral carotid massage or compression. However, in those with atherosclerotic carotid disease, this can sometimes cause partial or complete occlusion of the ipsilateral carotid artery or release of atheromatous emboli and subsequent stroke. Because of these risks, carotid artery massage is contraindicated in those with known or suspected carotid atherosclerotic disease. The rare syndrome of glossopharyngeal neuralgia is characterized by intense paroxysmal pain in the throat and neck accompanied by bradycardia or asystole, severe hypotension, and, if prolonged, seizures. Episodes of pain may be initiated by swallowing but also by chewing, speaking, laughing, coughing, shouting, sneezing, yawning, or talking. The episodes of pain always precede the loss of consciousness, see Chapter 20. Rarely, cardiac syncope may be due to bradyarrhythmias consequent to vagus nerve irritation caused by esophageal diverticula, tumors, or aneurysms in the region of the carotid sinus or by mediastinal masses or gallbladder disease. Decreased cardiac output. Syncope may occur as a result of a sudden and marked decrease in cardiac output. Causes are both congenital and acquired. Tetralogy of Fallot. The most common congenital malformation causing syncope does so by producing hypoxia due to right to left shunting. Other congenital conditions associated with cyanotic heart disease also may cause syncope. Ischemic heart disease and myocardial infarction, MI, aortic stenosis, hypertrophic cardiomyopathy with outflow tract obstruction, pulmonary hypertension, pulmonic valve stenosis, acute massive pulmonary embolism, atrial myxoma, and cardiac tamponade may sufficiently impair cardiac output to cause syncope. Exercise-induced or effort syncope may occur in aortic or subaortic stenosis and other states in which there is limited cardiac output and associated peripheral vasodilatation induced by the exercise. Exercise-induced cardiac syncope and exercise-induced cardiac arrhythmias may be related. In patients with valvular heart disease, the cause of syncope may be related to flow through the valve or to arrhythmias. Syncope in valvular disease may also be due to reduced cardiac output secondary to myocardial failure, to mechanical prosthetic valve malfunction, or to thrombus formation at a valve. Mitral valve prolapse generally is a benign condition, but, rarely, cardiac arrhythmias can occur. The most significant arrhythmias are ventricular. In atrial myxoma or with massive pulmonary embolism, a sudden drop in left ventricular output may occur. In atrial myxoma, syncope frequently is positional and occurs when the tumor falls into the AV valve opening during a change in position of the patient, thereby causing obstruction of the ventricular inflow. Decreased cardiac output also may be secondary to conditions causing an inflow obstruction or reduced venous return. Such conditions include superior and inferior vena cava obstruction, tension pneumothorax, constrictive cardiomyopathies, constrictive pericarditis, and cardiac tamponade. Patients may also inadvertently cause reduced venous return and hypotension during a prolonged coughing fit or breath hold. Syncope associated with aortic dissection may be due to cardiac tamponade but also may be secondary to hypotension, obstruction of cerebral circulation, or a cardiac arrhythmia. Hypovolemia. Acute blood loss, usually due to GI tract bleeding, may cause weakness, faintness, and syncope if sufficient blood is lost. Blood volume depletion by dehydration may cause faintness and weakness, but true syncope is uncommon except when combining dehydration and exercise. Both anemia and hypovolemia may predispose a patient to vasovagal symptoms and vasovagal syncope when standing upright. Hypotension. Several conditions cause syncope by producing a fall in arterial pressure. Cardiac causes were discussed earlier. The common faint, synonymous with vasovagal or vasodepressor syncope, is the most frequent cause of a transitory fall in blood pressure resulting in syncope. It often is recurrent, tends to occur in relation to emotional stimuli, and may affect 20% to 25% of young people. Less commonly, it occurs in older patients with cardiovascular disease. The common faint may or may not be associated with bradycardia. The patient experiences impairment of consciousness, with loss of postural tone. Acutely, signs of autonomic hyperactivity are common, including pallor, diaphoresis, nausea, and dilated pupils. After recovery, patients may have persistent pallor, sweating, and nausea. If they get up too quickly, they may black out again. Presyncopal symptoms of lethargy and fatigue, nausea, weakness, a sensation of an impending faint, yawning, ringing in the ears, and blurred or tunnel vision may occur. It is more likely to occur in certain circumstances, such as in a hot, crowded room, especially if the affected person is volume depleted and standing for a prolonged period, although it may still occur when sitting upright. Venipuncture, the sight of blood, or a sudden painful or traumatic experience may precipitate syncope. When the patient regains consciousness, there usually is no confusion or headache, although weakness is frequent. As in other causes of syncope, if the period of cerebral hypoperfusion is prolonged, urinary incontinence and a few clonic movements may occur. Convulsive syncope. Orthostatic syncope occurs when autonomic factors that compensate for the upright posture are inadequate. This can result from a variety of clinical disorders. Blood volume depletion or venous pooling may cause syncope when the affected person assumes an upright posture. Orthostatic hypotension resulting in syncope also may occur with drugs that impair sympathetic nervous system function. Diuretics, antihypertensive medications, nitrates, arterial vasodilators, sildenafil, calcium channel blockers, monoamine oxidase inhibitors, phenothiazines, opiates, L-DOPA, alcohol, and tricyclic antidepressants all may cause orthostatic hypotension. Patients with postural orthostatic tachycardia syndrome, POTS, frequently experience orthostatic symptoms without orthostatic hypotension, but syncope can occur occasionally. Data suggest that there is sympathetic activation in this syndrome. Garland et al. 2007. Autonomic nervous system dysfunction resulting in syncope due to orthostatic hypotension may be a result of primary autonomic failure due to Shy-Drager syndrome, multiple system atrophy, or Riley-Day syndrome. Neuropathies that affect the autonomic nervous system include those of diabetes mellitus, amyloidosis, Guillain-Barré syndrome, acquired immunodeficiency syndrome, AIDS, chronic alcoholism, hepatic porphyria, beriberi, autoimmune subacute autonomic neuropathy, and small fiber neuropathies. Rarely, subacute combined degeneration, syringomyelia, and other spinal cord lesions may damage the descending sympathetic pathways, producing orthostatic hypotension. Accordingly, conditions that affect both the central and peripheral baroreceptor mechanisms may cause orthostatic hypotension. Benefrock, 2008. Cerebrovascular ischemia. Syncope occasionally may result from reduction of cerebral blood flow in either the carotid or vertebrobasilar system in patients with extensive occlusive disease. Most frequently, the underlying condition is atherosclerosis of the cerebral vessels, but reduction of cerebral blood flow due to cerebral embolism, mechanical factors in the neck, e.g., severe osteoarthritis, and arteritis, e.g., Takayasu disease or cranial arteritis, may be responsible. In the subclavian steal syndrome, a very rare impairment of consciousness is associated with upper extremity exercise and resultant diversion of cerebral blood flow to the peripheral circulation. In elderly patients with cervical skeletal deformities, certain head movements such as hyperextension or lateral rotation can result in syncope secondary to vertebrobasilar arterial ischemia. In these patients, associated vestibular symptoms are common. Occasionally, cerebral vasospasm secondary to basilar artery migraine or subarachnoid hemorrhage may be responsible. Insufficiency of the cerebral circulation frequently causes other neurological symptoms, depending on the circulation involved. Reduction in blood flow in the carotid circulation may lead to loss of consciousness, lightheadedness, giddiness, and a sensation of an impending faint. Reduction in blood flow in the vertebrobasilar system also may lead to loss of consciousness, but dizziness, lightheadedness, drop attacks without loss of consciousness, and bilateral motor and sensory symptoms are more common. However, dizziness and lightheadedness alone are not symptoms of vertebrobasilar insufficiency. Syncope due to compression of the vertebral artery during certain head and neck movements may be associated with episodes of vertigo, disequilibrium, or drop attacks. Patients may describe blackouts on looking upward suddenly or on turning the head quickly to one side. In general, symptoms persist for several seconds after the movement stops. In Takayasu disease, major occlusion of blood flow in the carotid and vertebrobasilar systems may occur. In addition to fainting, other neurological manifestations are frequent. Pulsations in the neck and arm vessels usually are absent, and blood pressure in the arms is unobtainable. The syncopal episodes characteristically occur with mild or moderate exercise and with certain head movements. Cerebral vasospasm may result in syncope, particularly if the posterior circulation is involved. In basilar artery migraine, usually seen in young women and children, a variety of brainstem symptoms also may be experienced, and it is associated with a pulsating headache. The loss of consciousness usually is gradual, but a confusional state may last for hours. Metabolic disorders. A number of metabolic disturbances, including hypoglycemia, anoxia, and hyperventilation-induced alkalosis, may predispose affected persons to syncope, but usually only lightheadedness and dizziness are experienced. The abruptness of onset of loss of consciousness depends on the acuteness and reversibility of the metabolic disturbances. Syncope due to hypoglycemia usually develops gradually. The patient has a sensation of hunger. There may be a relationship to fasting, a history of diabetes mellitus, and a prompt response to ingestion of food. Symptoms are unrelated to posture but may increase with exercise. During the syncopal attack, no significant change in blood pressure or pulse occurs. Hypoadrenalism may give rise to syncope by causing orthostatic hypotension. Disturbances of calcium, magnesium, and potassium metabolism are other rare causes of syncope. Anoxia may produce syncope because of the lack of oxygen or through the production of a vasodepressor type of syncope. A feeling of lightheadedness is common, but true syncope is less common. Patients with underlying cardiac or pulmonary disease are susceptible. In patients with chronic anemia or certain hemoglobinopathies that impair oxygen transport, similar symptoms may occur. Syncopal symptoms may be more prominent with exercise or physical activity. Hyperventilation-induced syncope usually has a psychogenic origin. During hyperventilation, the patient may experience paresthesia of the face, hands, and feet, a buzzing sensation in the head, lightheadedness, giddiness, blurring of vision, mouth dryness, and occasionally tetany. Patients often complain of tightness in the chest and a sense of panic. Symptoms can occur in the supine or erect position and are gradual in onset. Rebreathing into a paper bag relieves the symptoms. During hyperventilation, a tachycardia may be present, but blood pressure generally remains normal. Miscellaneous causes of syncope. More than one mechanism may be responsible in certain types of syncope. Both vasodepressor and cardioinhibitory factors may be operational in common presentations of vasovagal syncope. In cardiac syncope, a reduction of cardiac output may be due to a single cause such as obstruction to inflow or outflow or a cardiac arrhythmia, but multiple factors are frequent. Situational syncope, such as is associated with cough, tussive syncope, and micturition, are special cases of reflex syncope. In cough syncope, loss of consciousness occurs after a paroxysm of severe coughing. This is most likely to occur in obese men, usually smokers or patients with chronic bronchitis. The syncopal episodes occur suddenly, generally after repeated coughing but occasionally after a single cough. Before losing consciousness, the patient may feel lightheaded. The face often becomes flushed secondary to congestion, and then pale. Diaphoresis may be present, and loss of muscle tone may occur. Syncope generally is brief, lasting only seconds, and recovery is rapid. Several factors probably are operational in causing cough syncope. The most significant is blockage of venous return by raised intrathoracic pressure. In weightlifting syncope, a similar mechanism is operational. Micturition syncope most commonly occurs in men during or after micturition, usually after arising from bed in the middle of the night to urinate in the erect position. There may be a history of drinking alcohol before going to bed. The syncope may result from sudden reflex peripheral vasodilatation caused by the release of intravesicular pressure and bradycardia. The relative peripheral vasodilatation from recent alcohol use and a supine sleeping position is contributory because blood pressure is lowest in the middle of the night. The syncopal propensity may increase with fever. Rarely, micturition syncope with headache may result from a pheochromocytoma in the bladder wall. Defecation syncope is uncommon, but it probably shares the underlying pathophysiological mechanisms responsible for micturition syncope. Convulsive syncope is an episode of syncope of any cause that is sufficiently prolonged to result in a few clonic jerks. The other features typically are syncopal and should not be confused with epileptic seizures. Other causes of situational syncope include diving and the postprandial state. Syncope during sexual activity may be due to neurocardiogenic syncope, coronary artery disease, or the use of erectile dysfunction medications. Rare intracranial causes of syncope include intermittent obstruction to cerebrospinal fluid, CSF, flow such as with a third ventricular mass. Rarely, syncope can occur with Arnold-Chiari malformations, but these patients usually have other symptoms of brainstem dysfunction. Investigations of patients with syncope. In the investigation of the patient with episodic impairment of consciousness, the diagnostic tests performed depend on the initial differential diagnosis. It is best to individualize investigations, but some measurements such as hematocrit, blood glucose, and ECG are always appropriate. A resting ECG may reveal an abnormality of cardiac rhythm or conduction or suggest the presence of underlying ischemic or congenital heart disease. In the patient suspected of cardiac syncope, a chest radiograph may show evidence of cardiac hypertrophy, valvular heart disease, or pulmonary hypertension. Other non-invasive investigations that may be helpful include echocardiography, exercise stress testing, radionuclide cardiac scanning, prolonged Holter monitoring for the detection of cardiac arrhythmias, and cardiac magnetic resonance imaging, MRI. Echocardiography is useful in the diagnosis of valvular heart disease, cardiomyopathy, atrial myxoma, prosthetic valve dysfunction, pericardial effusion, aortic dissection, and congenital heart disease. Holter monitoring detects twice as many ECG abnormalities as those discovered on a routine ECG and may disclose an arrhythmia at the time of a syncopal episode. Holter monitoring typically for a 24-hour period is usual, although longer periods of recording may be required, typically up to 30 days. Implantable loop recorders can provide long-term rhythm monitoring in patients suspected of having a seldom but highly symptomatic cardiac arrhythmia. Cron et al. 2004. Exercise testing and electrophysiological studies are useful in selected patients. Exercise testing may be useful in detecting coronary artery disease, and exercise-related syncopal recordings may help to localize the site of conduction disturbances. Exercise testing should be considered in anyone with a history of exertional symptoms. Consider tilt table testing in patients with unexplained syncope in high-risk settings or with recurrent faints in the absence of heart disease. Kapoor, 1999. False positives occur, and 10% of healthy persons may faint during the test. Tilt testing frequently uses pharmacological agents such as nitroglycerin or isoproterenol, which increase sensitivity but decrease specificity. The specificity of tilt table testing is approximately 90%, but the sensitivity differs in different patient populations. In patients suspected to have syncope due to cerebrovascular causes, non-invasive diagnostic studies including Doppler flow studies of the cerebral vessels and MRI or magnetic resonance angiography may provide useful information. The American Academy of Neurology recommends that carotid imaging not be performed unless there are other focal neurological symptoms. Langer-Gould et al. 2013. Cerebral angiography is sometimes useful. Electroencephalography, EEG, is useful in differentiating syncope from epileptic seizure disorders. EEG should be obtained only when a seizure disorder is suspected and generally has a low diagnostic yield. Poliquin-Lesner and Moore, 2009. A systematic evaluation can establish a definitive diagnosis in 98% of patients. Brignol et al. 2006. Neurally mediated, vasovagal or vasodepressor syncope was found in 66% of patients, orthostatic hypotension in 10%, primary arrhythmias in 11%, and structural cardiopulmonary disease in 5%. Initial history, physical examination, and a standard ECG established a diagnosis in 50% of patients. A risk score such as the San Francisco Syncope Rule, SFSR, can help to identify patients who need urgent referral. The presence of cardiac failure, anemia, abnormal ECG, or systolic hypotension helps to identify these patients, Perry and Tan, 2010. A systematic review of the SFSR accuracy, Saxilato et al., 2011, found that the rule cannot be applied safely to all patients and should only be applied to patients for whom no cause of syncope is identified. The rule should be used only in conjunction with clinical evaluation, particularly in elderly patients. The risk stratification of syncope in the emergency department, ROSE, study is another risk stratification evaluation of patients who present to the emergency department, Reed et al., 2010. Independent predictors of 1-month serious outcome were elevated brain natriuretic peptide concentration, positive fecal occult blood, hemoglobin of 90 grams per liter or less, oxygen saturation of 94% or less, and Q-wave on the ECG. Although these risk scores can be used, there has been limited external validation, and there is no evidence to support that their use leads to better clinical outcomes than with unstructured clinical judgment, Shen et al., 2017. In summary, the initial and most important parts of the evaluation of a patient with syncope are a detailed history from the patient and any witnesses of the syncopal event, followed by a thorough physical examination with a focus on the neurological and cardiovascular findings. It is recommended that all patients receive an ECG as part of an initial syncope evaluation. It is reasonable for most patients to undergo at least limited laboratory testing in the acute setting to rule out anemia and hypoglycemia. Beyond this, imaging and laboratory testing should be individualized and may not be necessary if the history and physical are highly suggestive of vasovagal syncope and if the exam and ECG show no concerning findings. In 2017, the American College of Cardiology, American Heart Association, and the Heart Rhythm Society released a joint guideline on the evaluation and management of patients with syncope that may further guide the clinician in the care of these patients, Shen et al., 2017. Seizures. Seizures can cause sudden, unexplained loss of consciousness in a child or an adult, see Chapter 100. Seizures and syncope are distinguishable clinically, and one should be familiar with the pathophysiology and clinical features for both. Pathophysiology. Epilepsy is the syndrome of recurrent unprovoked seizures. It is broadly dichotomized into generalized and partial, also known as focal. Generalized epilepsies are characterized by seizures that involve both hemispheres at onset rather than by electrographic spread. They are typically genetically predisposed and tend to manifest in childhood and adolescence in the form of discrete epilepsy syndromes, e.g., childhood absence epilepsy, juvenile myoclonic epilepsy. In contrast, partial or focal epilepsies are characterized by focal onset seizures that may or may not secondarily generalize, i.e., propagate to various parts of the brain. These are often termed localization-related or symptomatic due to the known local pathology, e.g., tumor, gliosis, abscess, that serves as an epileptogenic focus. If the pathology is suspected but not visualized, the term cryptogenic is instead used. History and physical examination. The most definitive way to diagnose epilepsy in the seizure type is clinical observation of the seizure, although this often is not possible, except when seizures are frequent. The history of an episode, as obtained from the patient and an observer, is of paramount importance. The neurologist should obtain a family history and should inquire about birth complications, central nervous system, CNS, infection, head trauma, and previous febrile seizures because they all may have relevance. The neurologist should obtain a complete description of the episode and inquire about any warning before the event, possible precipitating factors, and other neurological symptoms that may suggest an underlying structural cause. Important considerations are the age at onset, frequency, and diurnal variation of the events. Seizures generally are brief and have stereotypical patterns, as described previously. With complex partial seizures and tonic-clonic seizures, a period of postictal confusion is highly characteristic and is much slower to resolve than the typical post-syncopal confusion. Unlike some types of syncope, seizures are unrelated to posture and generally last longer. In a tonic-clonic seizure, cyanosis frequently is present, pallor is uncommon, and breathing may be stertorous. In children with autonomic seizures, Pathophysiology syndrome, syncope-like epileptic seizures can occur, although usually accompanied by other features that help to clarify the diagnosis. Koutroumanides et al., 2012. Tonic-clonic and complex partial seizures may begin at any age, although young infants may not demonstrate the typical features because of incomplete development of the nervous system. Specifically, the lack of CNS myelination in infants leads to more migratory jerking rather than the synchronous jerking seen with tonic-clonic seizures in children and adults. The neurological examination may reveal an underlying structural disturbance responsible for the seizure disorder. Perinatal trauma may result in asymmetries of physical development, cranial bruits may indicate an arteriovenous malformation, and space-occupying lesions may result in papilledema or in focal motor, sensory, or reflex signs. In the pediatric age group, mental retardation occurs in association with birth injury or metabolic defects. The skin should be examined for abnormal pigment changes and other dysmorphic features characteristic of some of the neurodegenerative disorders. If examination occurs immediately after a suspected tonic-clonic seizure, the neurologist should search for abnormal signs such as focal motor weakness, TOD paralysis, and reflex asymmetry, and for pathological reflexes such as a Babinski sign. Such findings may help to confirm that the attack was a seizure and suggest a possible lateralization or location of the seizure focus. Seizure classification. Seizure classification is based on their functional distribution and on the structural neuroanatomy of the brain. See Chapter 100. The location and extent of a seizure's involvement is reflected in its clinical manifestation, termed its semiology. Absence seizures. The onset of absence seizures is usually between the ages of 5 and 15 years, and a family history of seizures is present in 20% to 40% of patients. The absence seizure is a well-defined clinical and electrographic event. The essential feature is an abrupt, brief episode of decreased awareness without any warning, aura, or postictal symptoms. At the onset of the absence seizure, there is an abrupt interruption of activity, or behavioral arrest. A simple absence seizure is characterized clinically only by an alteration of consciousness. Characteristic of a complex absence seizure is an alteration of consciousness and other signs such as minor motor automatisms, repetitive purposeless movements, most often fluttering of the eyelids. During a simple absence seizure, the patient remains immobile, breathing is normal, skin color remains unchanged, postural tone is not lost, and no motor manifestations occur. After the seizure, the patient immediately resumes the previous activities and may be unaware of the attack. An absence seizure generally lasts 10 to 15 seconds, but it may be shorter or as long as 40 seconds. Complex absence seizures have additional manifestations such as diminution of postural tone that may cause the patient to fall, an increase in postural tone, minor clonic movements of the facial musculature or extremities, minor face or extremity automatisms, or autonomic phenomena such as pallor, flushing, tachycardia, piloerection, mydriasis, or urinary incontinence. If absence seizures are suspected, office diagnosis is frequently possible by having the patient hyperventilate for 3 to 4 minutes, which often, although not always, induces an absence seizure. Tonic-Clonic Seizures. The tonic-clonic seizure is the most dramatic manifestation of epilepsy and is characterized by motor activity and loss of consciousness. Tonic-clonic seizures may be the only manifestation of epilepsy or may be associated with other seizure types. In a primary generalized tonic-clonic seizure, the affected person generally experiences no warning or aura, although a few myoclonic jerks may occur in some patients. The seizure begins with a tonic phase, during which there is sustained muscle contraction lasting 10 to 20 seconds. Following this phase is a clonic phase characterized by recurrent synchronous muscle contractions or rhythmic jerking. During a tonic-clonic seizure, a number of autonomic changes may be present, including an increase in blood pressure and heart rate, apnea, mydriasis, urinary or fecal incontinence, piloerection, cyanosis, and diaphoresis. Injury may result from a fall, shoulder dislocation, or tongue biting. In the postictal period, consciousness returns quite slowly, and the patient may remain lethargic and confused for a variable period. The patient may remain somnolent and wish to sleep for many hours. Pathologically brisk reflexes may be elicitable. Some generalized motor seizures with transitory alteration of consciousness may have only tonic or only clonic components. Tonic seizures consist of an increase in muscle tone, and the alteration of consciousness generally is brief. Clonic seizures have a brief impairment of consciousness and bilateral clonic movements. Recovery may be rapid, but if the seizure is more prolonged, a postictal period of confusion may be noted. Complex partial seizures. In a complex partial seizure, the first seizure manifestation may be an alteration of consciousness, but the patient frequently experiences an aura or warning symptom. The seizure may have a simple partial onset that may include motor, sensory, visceral, or psychic symptoms. The patient initially may experience hallucinations or illusions, affective symptoms such as fear or depression, cognitive symptoms such as a sense of depersonalization or unreality, or aphasia. The particular symptoms are tightly correlated to the neuroanatomy of the seizure onset zone and eventually the extent of propagation. The complex partial seizure generally lasts 1 to 2 minutes but may be shorter or longer. If it propagates widely, it may become secondarily generalized and evolve into a tonic-clonic convulsion. During a complex partial seizure, automatisms, generally more complex than those in absence seizures, may occur. The automatisms may involve continuation of the patient's activity before the onset of the seizure, or they may be new motor acts. Such automatisms are variable but frequently consist of oral automatisms, chewing or swallowing movements, lip smacking, or automatisms of the extremities, including fumbling with objects, walking, or trying to stand up. The duration of the postictal period after a complex partial seizure is variable, with a gradual return to normal consciousness in normal response to external stimuli. Table 2.2 provides a comparison of absence seizures and complex partial seizures. Investigations of seizures. In the initial investigations of the patient with tonic-clonic or complex partial seizures, one should perform a complete blood cell count, urinalysis, biochemical screening, and determinations of blood glucose level and serum calcium concentration. Laboratory investigations generally are not helpful in establishing a diagnosis of absence seizures. In infants and children, consider biochemical screening for amino acid disorders. CSF examination is not necessary in every patient with a seizure disorder and should be reserved for those in whom a recent seizure may relate to an acute CNS infection. MRI is the imaging modality of choice for the investigation of patients with suspected seizures. It is superior to computed tomography and increases the yield of focal structural disturbances. EEG provides laboratory support for a clinical impression and helps to classify the type of seizure. Epilepsy is a clinical diagnosis. Therefore, an EEG cannot confirm the diagnosis with certainty unless the patient has a clinical event during the recording. Normal findings on the EEG do not exclude epilepsy, and minor nonspecific abnormalities do not confirm epilepsy. Some patients with clinically documented seizures show no abnormality even after serial or prolonged EEG recordings, including with special activation techniques. The EEG is most frequently helpful in the diagnosis of absence seizures. EEG supplemented with simultaneous video monitoring may document events of loss or alteration of consciousness, allowing for a strict correlation between EEG changes and the clinical manifestations in question. Video EEG is useful in distinguishing epileptic seizures from non-epileptic phenomena. In most patients, an accurate diagnosis requires only a carefully taken clinical history, physical examination, and the aforementioned investigations. Others present a diagnostic dilemma and may require more extensive and invasive testing. Psychogenic non-epileptic spells. Non-epileptic spells are paroxysmal episodes of altered behavior that superficially resemble epileptic seizures but lack the expected EEG epileptic changes. Ettinger et al. 1999. However, 10%–20% of patients with non-epileptic spells also experience epileptic seizures and vice versa. In such cases, carefully determining semiological differences among the spell types is important when the spells are ongoing despite seemingly appropriate interventions. A diagnosis often is difficult to establish based on the initial history alone. Establishing the correct diagnosis often requires observation of the patient's clinical episodes, but complex partial seizures of frontal lobe origin may be difficult to distinguish from non-epileptic spells. Most frequently, they superficially resemble tonic-clonic seizures, with whole body shaking and unresponsiveness. They generally are abrupt in onset, typically occur in the presence of other people, and do not occur during sleep. Motor activity is incoordinated, but urinary incontinence and physical injury are uncommon. Non-epileptic spells tend to be more prolonged than tonic-clonic seizures. Pelvic thrusting and back arching are common. Eye closure is common in non-epileptic spells, whereas the eyes tend to be open in epileptic seizures. Chung et al. 2006. During and immediately after the spell, the patient may not respond to verbal or painful stimuli. Cyanosis does not occur, and focal neurological signs and pathological reflexes are absent. PNES syncope without prominent motor activity can resemble. These spells are not uncommon and are often referred to as psychogenic pseudosyncope. Tanmot et al. 2013. The apparent loss of consciousness in these patients may be longer than in syncope. The diagnosis can be distinguished from syncope if tilt table testing fails to document a decrease in heart rate or blood pressure. In the patient with known epilepsy, consider the diagnosis of non-epileptic spells when previously controlled seizures become medically refractory. The patient should undergo psychological assessments because most affected persons are found to have specific psychiatric disturbances. In this patient group, a high frequency of hysteria, depression, anxiety, somatoform disorders, dissociative disorders, and personality disturbances is recognized. A history of physical or sexual abuse is also more prevalent in patients with PNESs. At times, a secondary gain is identifiable, although the absence of an identified gain or trigger should not preclude the diagnosis. In some patients with PNESs, the clinical episodes frequently precipitate by suggestion, by certain clinical tests such as hyperventilation and photic stimulation, and by placebo procedures such as intravenous saline infusion, tactile, vibration, stimulation, or pinching the nose to induce apnea. Hyperventilation and photic stimulation also may induce epileptic seizures, but their clinical features usually are distinctive. Some physicians avoid the use of placebo procedures because of the potential for an adverse effect on the doctor-patient relationship. Para et al. 1998. Findings on the EEG in patients with PNESs are normal during the clinical episode, demonstrating no evidence of an ictal process. However, it is important to note that a number of organic conditions may present with similar behavioral and motor symptoms in a non-epileptiform EEG. Kaplan et al. 2011. These may include conditions such as frontal lobe seizures, limb-shaking transient ischemic attacks, and paroxysmal dyskinesias, and a careful clinical history and adjunct testing are paramount. With the introduction of long-term ambulatory EEG monitoring, correlating the episodic behavior of a patient with the EEG tracing is possible, and PNESs are distinguishable from epileptic seizures. Table 2.3 compares the features of PNES with those of epileptic seizures. Although several procedures are used to help distinguish epileptic seizures from PNESs, none of these procedures have both high sensitivity and high specificity. No procedure attains the reliability of EEG video monitoring, which remains the standard diagnostic method for distinguishing between the two. Cuthill and Espire, 2005. Miscellaneous causes of altered consciousness. In children, alteration of consciousness may accompany breath-holding spells and metabolic disturbances. Breath-holding spells and seizures are easily distinguished. Most spells start at 6 to 28 months of age, but they may occur as early as the first month of life. They usually disappear by 5 or 6 years of age. Breath-holding spells may occur several times per day and appear as either cyanosis or pallor. The trigger for cyanotic breath-holding spells is usually a sudden injury or fright, anger, or frustration. The child initially is provoked, cries vigorously for a few breaths, and stops breathing in expiration, whereupon cyanosis rapidly develops. Consciousness is lost because of hypoxia. Although stiffening, a few clonic movements, and urinary incontinence occasionally are observed, these episodes can be clearly distinguished from epileptic seizures by the history of provocation and by noting that the apnea and cyanosis occur before any alteration of consciousness. In these children, findings on the neurological examination and the EEG are normal. The provocation for pallid breath-holding is often a mild painful injury or a startle. The infant cries initially and then becomes pale and loses consciousness. As in the cyanotic type, stiffening, clonic movements, and urinary incontinence may rarely occur. In the pallid infant syndrome, loss of consciousness is secondary to excessive vagal tone, resulting in bradycardia and subsequent cerebral ischemia, as in a vasovagal attack. Breath-holding spells do not require treatment, but when intervention is required, levetiracetam, Keppra, is effective for prophylaxis at ordinary anticonvulsant doses. Several pediatric metabolic disorders may have clinical manifestations of alterations of consciousness, lethargy, or seizures. See Chapter 90.